think I'll start now if that's okay. Okay, I'll start. Hi everyone, thanks for joining. My name is Anisah. I'm an F1 working in Birmingham, and today I'm going to be starting off the dermatology teaching series for Mind the Bleep. So today we're going to be going over an introduction to dermatology. So in terms of what we'll talk about today, we'll talk about the basic anatomy of the skin. We'll talk about terminology used in dermatology to describe cutaneous signs. We'll go through a framework on how we can use that to describe the cutaneous signs. We'll talk about how we can systematically approach examining from a dermatology perspective, so looking at the skin, the hair, the nails, and how we can summarize that all together. And if there's any questions, feel free to put them in the chat and then I can answer them as we go along or at the end. Okay, so this is very basic, but just as a recap. So when we're thinking about the skin, we're thinking about the three main layers. So we've got the uppermost layer, the epidermis, and we've got the dermis, and we've got the subcutaneous tissue or the fat layer. So we'll talk a bit about each of those layers. So starting off with the epidermis is a majority made up of keratinocytes. It also contains melanocytes, so they're responsible for creating the pigment in the skin. And then the epidermis can be divided into 4 or 5 different layers, and I'll go into those layers in a second. Then we've got the dermis. So the dermis, just below the epidermis, they're connected via the dermo-epidermal junction. So the dermis is composed of a superficial and a deeper layer. So the superficial layer is the papillary layer, and the deeper layer is the reticular layer. So there's lots of things going on in the dermis. We've got mast cells, fibroblasts, blood vessels, etc., etc. There's lots of stuff in the dermis. And then we've got the subcutaneous tissue, and this is essentially the store of adipose tissue. So I'm not going into too much detail of this for now, but this is just an overview of the main layers. And then in terms of the epidermis, so I mentioned that we can divide that into 4 or 5 different layers. So we've got the different stratum layers. So we've got the stratum corneum, stratum lucidum, granulosum, spinosum, and basale. So if I just briefly talk about what each of those layers are composed of, this is an acronym that I like to use to remember what the different layers are. So come, let's get sunburnt. So starting from corneum, so starting from the top, corneum, come, let's get sunburnt. That's just a quick way to remember it. So talking about the different layers, so at the stratum basale, so this is where the mitosis, so replication of the keratinocytes occurs. And then we've got the stratum spinosum. So this is also known as the prickly layer. So it's where the keratinocytes are joined by the tight intercellular junctions. So those are known as desmosomes. Then we've got the stratum granulosum. So here we have things like lipids and waterproofing molecules. This is where they're secreted. And then we've got the stratum lucidum. So this is a thin, very thin, transparent layer of keratinocytes. So the stratum lucidum is actually only present in areas of thicker skin. So for example, the palms or the soles of the feet. So it's not present in all over the body. And its main role is to reduce friction between the layer above and below, so between the stratum granulosum and stratum corneum. And it also helps to protect the skin from moisture loss again, which is why it's important on the palms and soles. Then lastly, we've got the stratum corneum. So this is the visible layer at the top, and this is where the keratinocytes basically shed and become new cells, which are called corneocytes. So those are the four or five main layers of the epidermis. Okay, and then again, a very basic image, but this just illustrates the basic ultrastructure of the skin. So we can see the hair follicle that goes into the dermis. We've got the sweat pore, which again at the dermis going up to the top at the epidermis. As I mentioned before, in the dermis we've got things like the vessels. We can see sweat glands, nerves as well going downwards, and we've got the adipose tissue at the bottom in the subcutaneous fat. Okay, so that's just a very brief overview of the anatomy of the skin. So now we're going to be talking about dermatology history taking. So I can't see the chat, but if anyone wants to just put in maybe questions that you would ask when taking a dermatology specific history, and then we can see what other things we would ask as well. I don't know if I'm able to see the chat or not.
I'll read out when we get some responses.
Cool, thank you.
So we have if the patient has any rashes or lesions.
Nice. Cool, so that's thinking about like the presenting complaint. Is there anything maybe we'd want to know about past medical history, social history?
So we have a Socrates-based history, so site of the lesion, rash, onset, physical description, distribution, any associated symptoms, exacerbating and alleviating factors, any changes in medications.
Nice. Yeah, cool, well done. Those are all really good points. So yeah, we definitely can use Socrates when thinking about a dermatology history, and drug history as well is really important as well, which we'll talk about.
Yeah, and then we have itching.
Okay, nice. Cool, so let's break it down. So firstly, just following our normal structure for a history. So presenting complaint, find out a bit more about it, past medical history, drug history, social history, family history, and systems inquiry as well. So if we think about presenting complaint firstly, so it depends what the patient's coming in with, but common things that we might see in dermatology could include having a rash, skin lesion, itch, as someone mentioned, could be pain, or it could be more secondary characteristics, so things like blistering, discharge, bleeding. So for any of those symptoms, of course, you want to ask a bit more about them. So someone mentioned correctly, so we can use Socrates. So particularly for things like a rash, so finding out where it is, when it started, what it looks like, how it spread. Again, the same thing applies to an itch or to pain as well, which we commonly use Socrates for. So we just want to explore all those symptoms in as much detail as possible. In particular, we want to ask about if they've had any previous episodes of similar symptoms, if they've had any previous treatments. So for example, if they've had an itch, have they tried anything before? Has it helped? Has it gotten better? Has it gotten worse? And we also want to ask about infectious contacts as well, because it could be that, for example, an itch is related to something infectious. So we want to rule out an infectious cause of that as well. So that's the presenting complaint. And then, as we would with any history taking, we want to do a general systemic inquiry as well. So asking about things like a fever or weight loss, going through each of the systems systematically is important to make sure that it's not related to any other symptoms or any other specialty, not just dermatology. And then past medical history. So, of course, the most concerning feature we want to ask about is whether the patient has a history of skin cancer. So we want to know when it was first noted, if they've had any treatment, if like what stage the cancer's at. These are all important questions we want to know. And then any other dermatological conditions. We can ask about a history of atopy, which is important to rule out eczema. We can ask about IBD, so inflammatory bowel disease. This is important because we might be able to notice conditions like pyoderma gangrenosum or erythema nodosum. So it's important to know whether they've got a background of IBD or any other gastro conditions. Again, diabetes. So diabetes can cause acanthosis nigricans, which is when there's hyperpigmentation of the skin, particularly in areas like under the arms. And finally, we want to ask about allergies too, because something like an itch or a rash could be related to an allergy. So it's important to be aware of any of those. And then the drug history. So something that's really important in drug history is asking about patients' adherence to their medications. That's particularly important for conditions like eczema, because we tend to give patients loads of creams and ointments and things, and patients don't actually use them and the symptoms get worse. So we want to check whether they're actually using anything that was prescribed to them before. In terms of things like creams, we want to know specifically what they are. So is it an emollient? Is it a steroid? Is it an ointment? We could ask if the patients had any antibiotics, whether they completed the course. And for dermatology, it's quite important to ask about over-the-counter medications, or even skincare products as well, because they could affect the skin too. For the drug history, it can be quite useful to create a timeline, especially if new drugs have been introduced. So say patients just developed a rash and they started several medications over the course of the past week. It's important to create that timeline so we can try and identify what drug is causing the reaction, and then we can stop and start accordingly to work out what could be causing that reaction. So that's quite helpful as well. Then family history. So again, most importantly, we want to ask about family history of skin cancer. So what age did it start? Is the patient still alive? Did the cancer spread anywhere? Was it metastatic? What treatments did they try? And again, just asking about any other dermatological disease. So common ones are eczema, psoriasis, vitiligo. These are common conditions that can be seen that run in the family. And like I mentioned before, the age that it started. And then social history. So all the typical stuff you'd ask in a social history, but thinking specifically about dermatology. So occupation. So is there something at work that could be causing a reaction on their skin? Things like pets, any new clothing, skincare, like I mentioned before. stress. So conditions like eczema or psoriasis can be exacerbated by stress. So we want to ask about whether they've been under any stressful conditions recently. Sun exposure is quite important, especially in those with fairer skin and if they're at a risk for skin cancer. In particular, it's good to ask about whether the patient has lived abroad, because if they've lived in an area with high sun exposure, they could be at a higher risk. That's related to travel as well. And sunbed use as well can put them at a higher risk for skin cancer. And sexual history might be important for if we're thinking of if it's related to an STI or an infectious cause as well. Okay, so those are the main points that I think are important to cover in history taking for dermatology. If anyone's got any questions, just let me know in the chat. And if not, we can go on to talking about assessing the skin and the terminology that we can use.
Can't see any questions.
Cool, thanks. Okay, so in terms of assessing the skin, so it's important to have a kind of systematic approach to how we're going to do it. So the way that I like to structure it is starting off like you would with any normal examination like cardio-resp. So general inspection of the patient, and then a closer inspection at the area that we're looking at. So whether it's a lesion on the hand or scalp or wherever it is. Then palpation, so you want to palpate the lesion. And then a systemic examination, so looking at places like the mucous membranes, the nails, the hair, to make sure that you've not missed any other signs. So we'll go through what we would do in each of those steps. So starting off with inspection and palpation. So it's important that we use a structure to describing cutaneous signs to make sure that we're not missing any key terminology. So the way that I like to structure my approach is using this framework. So this framework kind of covers the important terminology that you should be using when describing a skin lesion. It doesn't apply to every skin lesion. So for example, for certain skin lesions, it might not have any secondary characteristics, so you're not going to mention that, but I'll go through some examples and it will make more sense how we can use all of these. So if we start off by talking about configuration and distribution. So does anyone know the difference between configuration and distribution when describing a skin lesion? I didn't either, so I don't expect anyone to know.
So Sabina has written, is configuration, pattern, and distribution the location / spread? And Emily has written configuration, lesions in relation to each other, and distribution, lesions in relation to the body.
Yeah, nice. That's exactly right. Well done, guys. So configuration, so you're thinking about how the lesions are arranged. So exactly like one of you said, it's how the lesions relate to each other. Whereas distribution, we're thinking about the anatomical location of the lesion. So if we start off by thinking about configuration, so here we're thinking about how the lesions are related to each other. So firstly, a discrete lesion. So here we've got one lesion by itself. So we would describe it as discrete. Whereas in contrast, if we look at grouped, here all the lesions are kind of grouped together very closely. So that's the difference between discrete and grouped. Then we've got linear. So here we can see that the lesions kind of form lines. So we would describe that as linear. And then here, the lesions we would say are disseminated. So they're in the same area, but they're not necessarily grouped together. So we would describe that as disseminated. And then another word that we commonly see is confluent or coalescing. So this means that the lesions are kind of overlapping or merging with each other. So here we've got multiple hypopigmented lesions, but we can see that they're kind of merging or coalescing with each other. So here's two pictures of examples of some skin lesions. So how would you describe the configuration of each of these two lesions? What words would you use?
So we've got one could be linear, and two is disseminated or discrete.
Okay, cool. So I agree. So number one, I would describe as linear because we can see that it's forming a clear line. And then number two, I can see why I would say disseminated as well, but I think disseminated kind of applies to when there's more, so quite a lot of lesions in the same area. Whereas here we can see that we've got two individual lesions. So we would describe these as two discrete lesions. Nice. So that's configuration. Distribution I'll come back to in a second. So then we've got color. So different words that we can use for color. So skin colored, so if it's the same color as the skin. Violaceous, so this tends to be when the lesion is a kind of dark pink purpley color. So violaceous, like the word violet. Purpuric, so this tends to be when it's more, I guess, dark red, brown in color. And then erythematous is when it's more pink red in color. And then we've also got hyperpigmented. So this is due to excess melanin, so more darker brown color. Whereas hypopigmented is the opposite. So this is due to dysfunction of the melanocytes, so the cells that produce melanin, the skin pigment. And then depigmented is the complete absence of melanin. So hypopigmented is where there's a bit less pigment, but if there's none at all, then we would describe it as depigmented. So just thinking about the words that we just spoke about, how would you describe each of these, the color of these lesions?
So we have one erythematous, two hyperpigmented.
Nice, well done. I agree, erythematous, so it's clearly quite red in color. We describe that as erythematous. And hyperpigmented, so it's a darker pigment than the surrounding skin. It's that dark brown color. We describe that as hyperpigmented. Well done. Okay, so we've spoken about configuration, spoken about color. So then we've got shape. So quite basically, if it looks round or oval in shape, we could say it's round or oval. Target lesions. So this is where we have concentric rings of varying colors. So if you look closely, we can see that we've got this small inner ring, which is a kind of darkish pink color. Then we've got a surrounding paler pink color. And then we've kind of got another border where it's a bit darker pink color. So we've got rings of different colors. We'd call these target lesions. Whereas annular lesions, this is where it's got a more pale center and then a darker border on the outside. So annular tends to be just two different colors. And then we can also use the term discoid or nummular. So this basically just means coin shaped. So if you imagine like a 1p coin, we tend to use it when there's multiple small round lesions. So we could describe them as round or oval as well. But typically for conditions like discoid eczema, we would describe it as discoid because it's got multiple of those coin-shaped lesions. Some other shapes. So polymorphic. So this is just a term to describe when the lesions are different shapes. So poly meaning multiple, morphic referring to shape, so multiple different shapes. Flat-topped, it's a bit difficult to see in this image, but if the lesion is sticking out but it's kind of flat at the top, we'd say flat-topped. Whereas when it forms a dome, then we would call it dome-shaped. And then irregular is another term that we might use when the lesion doesn't have a shape at all. So there's not really a term to describe this shape, we just say irregular. So here we've got two different lesions. How would you describe the shape of these lesions?
So we have 1 target lesion, 2 annular.
Nice, well done. I agree. So target lesion for the first one, we can see that we've got multiple rings of different colors. So some of these lesions, we can see 4 different rings. Whereas in the annular lesion, we can see the more pale center and then the more erythematous outside layer, which is how we would differentiate between a target lesion and an annular lesion. Cool. Okay, then just thinking about size. So this is not a kind of said rule, this is just something that I go by. But when trying to determine whether a lesion is small or large, we tend to use 10 millimeters as the cutoff size. So if the diameter of the lesion is less than 10 millimeters, then we would describe it as small. Whereas if the diameter is more than 10 millimeters, we would describe it as a large lesion. So that's just something useful to remember when thinking about whether it's a small or large lesion. And then another important concept is understanding the difference between a patch and a plaque. So does anyone know the difference between the two?
Sabina has written plaques are raised.
Cool, yep, exactly. So a plaque is raised. So because it's raised, it means that when you brush your hand over it, you'll be able to feel it, it's palpable. Whereas a patch is not palpable. So if you close your eyes and run your hand over the lesion, you won't be able to feel it. Nice. So now we're going to talk about primary morphology. So this is where it's important to know about the size of the lesion. So whether the diameter is less than 10 millimeters or more than 10 millimeters. So firstly, if we're thinking about a lesion that's less than 10 millimeters in diameter and it's flat, so when you run your hand over it, you can't feel it, that would be a macule. So like here, we can tell it's not raised, it's small, that's a macule. However, if it's small, but it's raised, so it's palpable, then we would describe that as a papule. So the difference between macule and papule is whether it's palpable or not. Then say that we've now got a lesion that's more than 10 millimeters in diameter. If you can't feel it, if it's not palpable, it's a patch. If it is palpable, so something like a psoriasis plaque, then we would call that a plaque. There's some other morphology to be aware of. So if the lesion is again small, so less than 10 millimeters, if it's raised and if it's filled with clear fluid, we would call this a vesicle. And similarly, if again we've got a lesion that's raised and filled with clear fluid, but it's more than 10 millimeters, so it's bigger, we would call this a bulla. So the difference between a vesicle and a bulla is basically the size of the lesion. Then we have nodules. So nodules are very similar to a bulla. The main difference is that it's more solid compared to the bulla. So the bulla was filled with fluid, whereas the nodule is solid. And then pustule. So a pustule is small, like a vesicle, but the main difference is that it's filled with pus rather than the clear fluid that you would have in a vesicle. Okay, and then a few others. So a comedo. So this is a blocked hair follicle. So there's no fluid as such in it, but it is palpable. Then a cyst. So a cyst is fluctuant. So if you palpate it, you'll be able to kind of move it around. And this is fluid filled. An abscess. So an abscess is a localized collection of pus. So abscesses tend to be bigger as well, so more than 10 millimeters in diameter. And then a wheal. So a wheal is where there's elevation of the skin due to dermal edema. So wheals you'll see in things like urticaria. Okay, I hope that made sense. I know there's a lot of different terminologies, but just going back, the main thing to do when you're assessing is work out, is it big or is it small? Is it palpable or is it not palpable? If it is palpable, is it hard or is it soft? And what's inside if it's palpable? Is it fluid filled? Is it pus filled? Can you move it around with your finger? Those are the main things to try and work out. So here we've got another 2 skin lesions. So how would you describe the primary morphology of these skin lesions?
So we have 1 is plaque and 2 papule.
Okay, so plaque and do you say, I think you said papule, right? So I understand why you said papule. So firstly, we'll talk about plaque. So it's hard to tell because we can't work out the diameter accurately from these images, but I agree, we can see that it's quite big. It goes over a large area of the hand and it's quite obviously palpable, so this would be a plaque. And then I understand why we said papule. They technically are papules because they're small and they're raised. In these images, you can see that the lesions are filled with pus, so that's why we've called them pustules here. But they are also papules. They're papules filled with pus, which we call pustules, but it's essentially the same thing. Okay, cool. Are there any questions so far? Just let me know, otherwise I'll continue.
Can't see any questions so far.
That's fine. Okay, so then we'll talk about border. So when we're talking about the border, terminology that we tend to use is if it's not well defined, we would say it's ill or poorly defined or circumscribed or demarcated. If you can clearly see the borders, we would say it's well circumscribed or defined or demarcated. So there's loads of different words that we can use. Easiest one to say is defined. So poorly defined or well defined. Here we can see that it's difficult to determine where the lesion ends in comparison to the surrounding skin. Whereas here, in this image of someone with vitiligo, you can very clearly see where the edge of the border is on the lesions. And then distribution. So earlier on, we were talking about the difference between configuration and distribution. So distribution, we're thinking about where the lesion is on the body anatomically. So when we're describing the distribution, firstly, we want to think about, is it symmetrical or asymmetrical on the body? So is it the same on both sides or is it different? Is it unilateral or bilateral? So is it on one side of the body or both sides? Is it localized or generalized? So is it focused on one area of the body or is it generalized, so over a very large area or over almost all of the body? Then when we've figured those things out, we can also give some specific names to the distribution if appropriate to the lesion. So for example, is it dermatomal? Does it follow the distribution of the dermatome? Seborrheic, so in areas of or where there's more sebaceous glands. So for example, across the nose, at the top of the scalp. Is it photodistributed? So photodistributed meaning it's on sun-exposed sites. So typically on the neck, on the face, on the arms, on the back of the neck, sometimes on the legs as well. So here are some images. How would you describe the distribution of these rashes?
Okay, so for one, we have symmetrical, bilateral lesions localized to the lower arm. I think it's actually lower legs.
Yeah, that's fine. Yeah.
And someone has also said photo distribution.
Okay,
And
cool.
the
Yeah.
number 2, we have malar rash.
Okay, nice. So yeah, well done. I agree. It's symmetrical. It's bilateral. It's on both of the legs. Yeah, it could be on a photo exposed site as well. I agree, photo distributed. So yeah, so this could be a malar rash. I've just used the term seborrheic. I think this is a patient with seborrheic dermatitis, but it's harder to kind of recognize in this patient because his skin tone is a bit darker. But in a seborrheic distribution, you typically see it on the nose, around the nose, the scalp, under the armpits. So if you can also see the lesion in these areas as well, that would also point towards a seborrheic distribution. Okay. Then we have the site of the lesion, so the anatomical site. So terms that we can use are extensor. So if it's on the extensor surfaces, typically the elbows and the knees. Flexural, so thinking about the flexural surfaces, including the axillae, the genital region, the cubital fossa. Palmoplantar, so this is a term used to describe palm, palmo, and plantar, the soles of the feet. Acral, so this is the distal areas, so the hands and the feet, so not necessarily just the soles, but the hands and feet in general. And then follicular, so similar to seborrheic, but in areas with increased sebaceous glands, so on the face, on the chest, on the axillae. So here we've got another two images. How would you describe the site of these skin lesions or rashes?
We have number 1 is flexural and number 2 palmoplantar.
Yeah, nice, well done. So here we're looking at someone's elbow, so it's on the flexural surface, the inside of the elbow. So this is probably a patient with eczema, atopic dermatitis. And then, yeah, well done, palmoplantar. So we can see it on the palms of the hands and on the soles of the feet. Cool. Okay, so those are all things that we want to think about when inspecting a lesion. Then we can go on to palpate the lesion. So when you're palpating a lesion, there's a couple of things that you want to be thinking about. So is the lesion raised or is it depressed? What's the consistency like of the lesion? So is it hard to touch? Is it firm? Is it soft? Does it fluctuate? So does it move around? Does it move around? Is it mobile or is it tethered to other localized structures? Is it wet to touch? Is it dry? Is it tender? So does the patient kind of flinch in pain when you touch it? The underlying tissue for the lesion, is there crust? What's the temperature like? Is it cool or warm? And is it smooth or rough as well? So I think, I can't remember the acronym now, but I think you can think about the T's and the S's, I think it is, when you're palpating a lesion. So you're thinking about, is it tethered? What's the texture like? What's the temperature like? Does it transilluminate? Things like that you want to think about when you're palpating the lesion. Okay, so I mentioned crust before. So does anyone know the difference between scale and crust?
Okay, so we have one response suggesting that crust is due to infection, so it's yellow, whereas scale is not and appears more white.
Okay. So I agree. So typically crust does tend to look a bit more yellow in color, whereas scale is more white in color. But it does depend. So scale is essentially keratin. So what we're seeing is visible fragments of the stratum corneum. When I was talking about the epidermis, we were talking about the different layers. So the stratum corneum, the layer at the top. So when those keratinocytes break down and they're deposited, so that's the scale that we're seeing at the top, and that does tend to be more white in color. Whereas crust is kind of dried secretions or dried serum or exudate. So it could be blood, it could be bacteria, it could be cellular debris. So it could be yellow in color. It could also be more red or brown in color. So it depends what that dried exudate is that's giving it the color. Okay, then another key concept, so vesicle versus pustule. So just to reiterate what we said before. So when you're thinking about a blister that contains clear fluid that becomes cloudy as the lesion becomes older, that's not a pustule. So it's important to look at the color of the fluid. But as it becomes cloudy, that doesn't mean it's a pustule. So that might still be a blister or a vesicle. Okay, so here's some images of scale versus crust. So here the scale, like we said, it's visible fragments of the stratum corneum. So here we can see that the scale is quite white, so it's got this kind of white silvery color to it. And here we've got crust. So this is a child with impetigo. And we can see that it's a bit yellow, but it's also a bit red and pink as well. So that's probably from dried blood. So it depends what that exudate is. Okay, and then some other secondary characteristics to be aware of and to be looking out for. So lichenification. So lichenification is thickening of the epidermis due to chronic scratching. So in conditions like eczema in particular, when patients keep scratching the lesion, it can cause thickening of the epidermis, which we call lichenification. An ulcer, so this is when there's loss of the epidermis and sometimes of the dermis as well. Excoriation, so this is loss of the epidermis associated with trauma. And then a fissure, so like you can see here, a fissure is a tear in the epidermis. And then just going back to ulcers, so there's some other terms that we can use to describe ulcers. So sloughy we would use if it's yellow or white and wet. So in this image, you can see that it's kind of yellow in color. It's evidently quite wet as well. We could also describe it as exudative. So if it's leaking fluid, we could say it's exudative. And if the lesion or ulcer bleeds easily, or if you touch it and it starts bleeding, we could describe that as friable, and that could indicate a sign of infection. Okay, so here we've got two images. How would you describe these secondary characteristics?
So we have one, lichenification.
I agree.
Okay, and for 2, someone's written sloughy ulcer with a question mark.
Okay, so this is actually scale. If it was sloughy, it would probably be more wet looking, whereas here I would say it looks quite dry. And it might be more like a white yellow color. Here, instead, we can see it's quite erythematous on the outside, and this white part around the outside, this is what we're referring to when we say scale. So this is the excess keratin around the lesion, which is why we describe it as scale. I hope that makes sense. Okay, let's keep going. So, cool. So those are the main terms to be aware of when describing skin lesions. And then, like I said, it's important to look at the patient systemically as well. So things or important areas that we want to look at when doing a dermatology examination are the hands and the elbows. So when you're looking at the hands, you can look for signs in the nails in particular, things like nail pitting, onycholysis, koilonychia, clubbing as well. When looking at the elbows, you want to look for rheumatoid nodules. So if you're thinking about rheumatoid arthritis, for example. Then the hair and scalp. So you want to look for signs of hair loss. So for example, alopecia areata, which you can see in this image here, or complete loss of the hair, so alopecia totalis. Hirsutism, so is there excess hair growth, for example, on the sides of the face or on the chin? Or hypertrichosis as well, which is also excess hair growth, but that's not related to hormonal changes, whereas hirsutism is. You want to look in the mucous membranes for any signs of bleeding or ulceration, and just a general systems review as well, looking for things like organomegaly and lymphadenopathy as well. So it's important to look at the patient as a whole. Just follow your general structure for examining. So look at them generally, then look at the hands, go up the elbows, look at the face, look at the abdomen and legs as well if necessary. So in these images, it's a bit hard to see in this one, but you can see that there's nail pitting in the nails here. We've got onycholysis, so separation of the nail bed, and koilonychia when the nails form a kind of spoon shape. We mentioned alopecia areata, where you lose kind of patches of hair, and ulceration in the mucous membranes. Okay, so I'm going to skip through this just because of time, but it's just recapping what we spoke about before. So just to reiterate, when assessing the skin, inspect generally, then closely, then palpate, and then do a systemic examination. So this is the framework that I was talking about before. So I'll go through an example of how I would use this framework to describe a skin lesion. So for example, let's say that we're given, or a patient comes in with these lesions, and these lesions are on the lower back and on both of their knees. So here, so we've got multiple lesions, so we'd say there are configuration. So the lesions are discrete, so we can see that they're separated, or mostly separated from each other. So we've got discrete lesions. They're erythematous, so they're kind of pink in color. We could describe these as oval-shaped lesions. And they're plaques because the diameter is more than 10 millimeters, and when we palpate it, it's raised, we can feel it. The border is well defined, and we know it's on both the knees, so it's bilateral, and we can't see from the image, but it's symmetrical as well. And it's on the lower back and on the extensor surfaces. So we've looked at the lesion, then we want to palpate the lesion. So what's the texture like? So the texture is rough, and in terms of secondary characteristics, we can see the white scale on the top. Also, it's not relevant, leave that out. And then we want to do a systemic examination as well to look for any associated signs or symptoms. So because this patient is presenting with signs of chronic plaque psoriasis, examples of things they might have could be pitting nails or signs of arthropathy. So then if we put that all together, the way that we could describe it is there are discrete erythematous oval plaqued shaped lesions with well-defined borders. The lesions are bilateral and symmetrical, sited on the lower back and extensor surfaces. The skin is rough in texture and there is scale present. On systemic examination, there is evidence of pitting nails and arthropathy. These findings are consistent with chronic plaque psoriasis. So that's how we could put all that information together to present our findings back. So we'll go through a couple of examples just to finish off. So does anyone want to have a go at just putting some words in the chat that you would use to describe this lesion or these lesions? It's a bit hard to see on this image.
We do have a question.
Oh yeah.
So is this structure how you would use to present it as an S-bar, as a presentation?
Yeah, I would definitely use it as an S-bar because I think it's important that if you're referring to another specialty that they know as much information as possible about the lesion, and this kind of makes sure that we don't miss any important details that they might want to know. So yeah, I would definitely use it. Okay, so yeah, if anyone wants to put any words in the chat as to how they would describe this patient's skin, and then we can kind of throw them together. I know that it's difficult. We obviously don't know the distribution or the site, so
So we have for the color, skin colored or slightly hyperpigmented, shape polymorphic.
okay. So I should have made it clearer, but I think the image is referring to the lighter bits. But yeah, if we're talking about these bits hyperpigmented, I think it's talking about the hypopigmented part. let's see what we've said. So I'd describe this as confluent because the lesions are kind of merging together or coalescing. It's referring to the hypopigmented part. They're irregular in shape. These are patches. Again, in derm it's hard to tell from images, but if we were to palpate it, we wouldn't be able to feel it. The borders are not well defined. Again, hard to tell from the image. It could be unilateral, could be bilateral. We don't know the site here. Because we can't feel it, there's no texture, there's no secondary characteristics. So here we've got confluent, hypopigmented, irregular patches. The borders ill-defined. We don't really know the distribution or site from the image. Okay. Okay, here's another example. What words would you use to describe these lesions?
So we have configuration is discrete, color is erythematous.
Nice.
And then we have discrete erythematous oval plaques with crusting unilateral on the lower arm.
Cool, yeah, that's really good, well done. So I agree, they're discrete, they're separate from each other. You can see that it's got a reddish border, so erythematous. Difficult to comment on the shape. It could be oval, could be round. These are plaques because they're bigger than 10 millimeters in diameter. They're raised. They've got, you can clearly see the borders. They're well defined. In this image, it's unilateral and it's on the arm, kind of on the flexural surface. Difficult to tell, but we can kind of see that it'd be rough to touch. And it's got crust present, it's ulcerating in the middle. And let's say when we palpate, it's exudative, so there's fluid coming out of the lesion. So in conclusion, we've got discrete erythematous round plaques with well-defined borders. It's unilateral on the, like someone said, on the lower arm, on the flexural surface. When palpating, the skin is rough to touch. There's ulceration and crusting present, and the ulcer is exudative. Well done. We'll do maybe one more. So we'll do this one. What words would you use to describe these lesions?
So Sabina has written grouped erythematous. and annular/irregular.
Okay. So yeah, so I agree that they're kind of grouped as well. We can use different terms. They're definitely grouped together. They're also kind of coalescing here, so we can see that these lesions are kind of merging together. Here it's a bit more discrete. There's different terms we can use. They're definitely erythematous in colour. I agree, they're annular, so we can see that they've got the outer rim, which is darker than the inside. It's difficult to see from this image. I think now they actually look more like patches. It's hard to tell, but they've got well-defined borders. We can assume here that it's unilateral, it's on the arm, and they don't have any texture or secondary characteristics. So we could say these are discrete/coalescing erythematous annular papules, patches, plaques, whatever they are, with well-defined borders. It's unilateral and present on the arm. Okay, so I'll stop there. I'll just run through those. This is a patient with vitiligo, erythema multiforme. Okay, so in conclusion, we've spoken a bit about the anatomy of the skin. We've spoken about common terminology that we use to describe cutaneous signs. And we've gone through a framework of how I would typically structure that. We can use that in an S-bar scenario or just when documenting what we found after examining a patient. We've spoken about what else we should look for in a systemic examination and how we would summarize that all together. And these are just some other resources that I think are quite useful for when revising how to describe skin lesions. Okay, and that's it. So if you guys have any questions, just let me know. Otherwise, thank you so much for listening.